Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we're going to talk about hyperbaric oxygen for carbon monoxide poisoning and the complete lack of evidence for that therapy. I guess I'm really biasing the audience early on, but we will hear from David Gerlink on that and just a little bit more stuff on carbon monoxide. Before we get to that, super quick, we opened up tickets for our Unburnable online cohort course. This is our burnout and flourishing course, preventing or eliminating burnout and promoting flourishing. And this is the 5th iteration, but we've dialed it in. The kinks are gone. This course kicks ass. It's 12 2-hour sessions. We record them in case you can't make a few of them, and group activities between to have discussions, and it's been fantastic. And people who are burnt out have been much better after the course, and a lot of people take it because they see the path in the distance on the horizon of burnout coming, and they want to take the steps to prevent it from ever happening. So if you're interested in that, just come to Unburnable, one word course, Unburnable course, all one word.com. Unburnablecourse.com. All right, let's get into the show. David Gerlink, hyperbaric oxygen for carbon monoxide. So then we start with the same question as always. Who are you and what do you do?
So I'm Dave Gerlink. I'm an internist in Toronto. I work at Sunnybrook Health Sciences Centre, one of the larger hospitals affiliated with the University of Toronto. And so that's my main clinical hat. I look after adult inpatients. I don't have any outpatient practice. My other hats, though, are I do clinical pharmacology and medical toxicology. So the clin pharm side of things, we have this consult service where we see patients with any kind of drug-related problem. We might go to the burn unit for a TEN patient. We see a lot of DRESS, what we used to call DRESS, drug hypersensitivity reactions, drug-induced liver injury, pretty much anything. And the tox side, I'm a toxicologist at the Ontario Poison Center. And so we cover anything you might call a poison center about, anything from a bad bupropion to carbon monoxide, just to snake bites. So.
And you have a particular interest in hyperbaric oxygen therapy for carbon monoxide. How'd that develop?
Yeah, so that happened about 20 years ago. I was doing a graduate degree because at U of T, you have to do a graduate degree if you want a job. And one of the courses was essentially a meta-analysis course of sorts. And because I was interested in toxicology at the time, I was looking for a topic. And this just was an area that really hadn't been analyzed in that way. I guess I should say systematic review, because it's not really the kind of thing that lends itself to mathematical sort of manipulation. But so I just fell into it as a product of one of my clinical interests and the fact that I needed to do something for a course. And so I ended up publishing the first Cochrane review on the topic, and we had a few additional reviews after that. And that's how I came to be interested in this area.
Absolutely. And so I'm going to start with a case. I think it's interesting. It opened up my eyes because during medical school, obviously, they teach us hyperbaric equals the solution to carbon monoxide. They drill it into us. And then I had never worked at a place that actually had hyperbaric. So we would call the tox center, they'd say transfer, and then the transferring center could figure out whether or not they're going to dive the patient. So I never really had to deal with this issue. But now, I was doing a shift at a place that had hyperbarics and had a patient who tried to kill himself in his garage, and he came in. We obviously suspected carbon monoxide poisoning already. He just wasn't speaking. His eyes were open, but he was totally unresponsive to anything we would do, pain, but he was maintaining his airway just fine. We had his CO level come back. It was like 32. And I'm like, all right, well, this is a patient we need to dive. So I call up the hyperbaric team, and they're like, well, is he cooperative? Will he swallow to clear his eustachian tubes? And I'm like, no, he won't do anything you ask. And they're like, well, we can't dive him. I'm like, wait, what? They're like, if he was a little better, he wouldn't need to be dived. If he was a little bit worse, then you can intubate him and we dive him. He's in that happy place where he'll do just fine on 100% O2. And I'm like, that's crazy talk. Do you want me to intubate him? They're like, no, he'll do fine. And I called up our tox center. They're like, I think we should dive him. And our hyperbarics guys said, well, if you could try to get ENT in there and put in eustachian tubes, then okay, but otherwise, no. And so we left the patient on 100% oxygen, and an hour later, he was better. He had, from our very non-specific neurologic testing, was completely intact. And I'm like, This guy who clearly I thought had to be dived didn't seem to need it. I don't know what his long-term neurologic sequelae are, but I think the short-term probably is indicative of that. And it just made me do a deep dive and realize the evidence is not as crystal clear as you know, Dave. So tell us a little bit, hearing that case and your own experience, why is it that this is put out there as an absolute high patients with neurologic symptoms should get dove, and yet the evidence doesn't seem to support that?
Well, to be fair, I think I certainly know many physicians who do hyperbaric medicine who wouldn't dive that patient, but there are some who would. And you look at references, let's say Goldfrank, the Bible of toxicology, you'll see a list of indications for hyperbaric oxygen, level above, I think, 25%. Oh, yeah, the patient you described just now would unquestionably, if you open the pages of Goldfrank, a book I admire very much and have contributed to, would end up getting recommended to dive. But I think the problem is that we can get into the evidence in a little bit. We just don't know if it does anything meaningful. And I think one of the problems here is our tendency to focus on the number, right? The carboxyhemoglobin, yours was 32%, right? Is that what I remember?
Exactly right.
Yeah. And I think this is maybe one of the most important points of the whole discussion. It is not true that carboxyhemoglobin is the fundamental cause of the injury that happens with carbon monoxide poisoning. Yes, it is true that carboxyhemoglobin binds much more avidly to hemoglobin than oxygen does, like 200, 240 times, right? And so, yes, it'll cause a functional anemia, just as methemoglobin will. But it does so much more than that. It poisons mitochondria directly. It really throttles oxidative phosphorylation in heart and brain tissue. It messes with neutrophils. It peroxidates lipids. It activates microglia, like stuff we don't think about. And I think it's kind of like this biochemical Swiss Army knife of misery. Like it's not just carboxyhemoglobin. So I think it does a lot more than just tinker with oxygen carrying capacity. And I think recommendation to in this case, someone might say it's the percentage, someone might say it's the symptoms, someone might say it's both, but we just don't know.
So let's zero in on that a little bit. So it's inarguable that hyperbarics clears the hemoglobin faster. Is that correct?
Yeah, this is really important. Yeah. So let's say for ease of math that I have a level of 50%. If I'm breathing room air, 21% oxygen, my concentration of carboxyhemoglobin will fall rather predictably, the half-life around 6 hours, right? So 6 hours from now it'll be 25, 6 hours later it'll be around 12, sort of predictable decline. Put me in 100% oxygen and it drops with a half-life, depending on the study, of around 72 minutes. And then if you put me in a chamber with oxygen that pressure is higher than atmospheric, it will fall much faster. Like 2 or 3 atmospheres might be a half-life of 20 minutes. So there's just no doubt that oxygen at pressures higher than atmospheric accelerates the clearance of carboxyhemoglobin. But again, carboxyhemoglobin, it's a marker, obviously, of exposure, but it's not an outcome.
So that's what I want to zone in on. So you talked about all the mitochondrial poisoning and all these other milieu of badness. Does hyperbaric actually fix that more rapidly?
I guess I'm going to be honest, Scott, I don't know that anyone really knows the answer to that because it's hard to measure these things, right? You can't really measure, I don't know, you can't really measure peroxynitrite formation, and you can't really measure lipid peroxidation, at least not in a good, there might be an animal model out there that I'm not aware of, but again, even if it does those things, what matters to us and to our patients is, are they neurologically better as a result? And I think that's where we don't know the answer.
Absolutely. So we have the disease-oriented outcome of rapid clearance of carboxyhemoglobin, but then we have the patient-important outcome, which should be neurologic outcome. So where do we stand on the evidence from your perspective on that, Dave?
Yeah, so it's more than half a dozen studies, randomized trials. They're, for the most part, not very good. And I think the reason you contacted me is because I wrote a piece a couple of years ago, a review of this topic. It was a pro-con debate in the British Journal of Clinical Pharmacology. And one of the luminaries in the field of hyperbaric wrote the opposing piece that, yes, we should use hyperbaric oxygen more frequently. And I adopted the other position that we shouldn't use it regularly. And in making the argument that we shouldn't, what I did was tackle the key studies that a proponent would zero on and say, the reason I'm recommend this patient go get to dive is this study right here. And that study, the main study out there, if someone wants to hang their hat on this, it was published in the New England Journal in 2002. It's a paper by Lynn Weaver, a lovely guy from Salt Lake City. And so it was a multi-center trial, 152 people enrolled within 24 hours of exposure. So they all had symptomatic carbon monoxide exposure. They didn't let pregnant people in. They didn't let moribund people in. They didn't let children in. And what they did is they randomized them to 3 sessions of hyperbaric versus normobaric oxygen. And the reason why that trial, if you look at that trial, in fact, I remember reading it when it came out, because this was around the time my tox training was finishing. And I was impressed by the paper because on the surface, what they did, they found in their primary outcome that 2 groups of patients, normobaric versus hyperbaric, and the people who had hyperbaric oxygen had at the 6-week mark an incidence of cognitive sequelae, a bad outcome, of around 25%. The people who had the normobaric, the placebo arm, had 46%. So that's a big difference, like a 20% difference. The implication there is that you need to treat 5 people like these to prevent 1 instance of cognitive sequelae. And so if you just looked at the trial, if you just read the abstract, you say, wow, well, that settles it, right? There's our answer. And it was only in the context of this course that I was describing to you, and writing the first Cochrane review on the topic, that I dug into the literature a bit more with some colleagues in Australia. And I came to realize something that I think is pretty important. All trials have limitations, and I do research, but I'm not a trialist, and so it's easy to throw stones. And I don't mean to throw stones. It was good that they did the study. But I think there were 4 really important limitations on that trial that I think should give us pause before we just reflexively say, hey, we should dive the next patient who meets these criteria. The first is that the randomization process did not work. The patients who got normobaric oxygen, the control arm, were just sicker, right? The average duration of exposure was about twice as long as in the HBO arm. They had a 4-fold higher risk of cerebellar dysfunction. So they were very clearly different at baseline, right? If you want to know if a treatment works, you do a randomized trial. And one of the reasons a randomized trial tells you something important is because patients were otherwise similar at baseline, except for the intervention. And that wasn't the case here. That's limitation number 1. The patients were just different at baseline. Very high likelihood of unblinding, right? So a lot of the patients in the interim analyses that they published, patients who in one group were mysteriously less able to tolerate the chamber than the other, right? I think I missed an important point a moment ago. The reason why this trial is so vaunted by people who believe in hyperbaric oxygen is because it was really the only trial to do a decent job of sham dives. Most other trials, the patients weren't dive, they were just dive versus, face mask. And it wasn't a properly conducted trial. This was, but the problem is that it's pretty clear. The patients and even the outcome assessors could tell, hey, your ears popped, you weren't tolerant of the chamber. That kind of gives you a clue as to what arm they were in. They didn't handle their missing data very well, but I think the key limitation of this study that was changing the primary outcome. If you dig into the old literature, what's clear is that what they initially intended to study, their own words make this clear, was they wanted to know if hyperbaric oxygen reduced the incidence of delayed neurologic sequelae. So let me just disambiguate that a little bit. So when someone comes into the ED with symptoms of carbon monoxide poisoning, you can put them into 2 general bins. People who have, based upon their outcome, they either have persistent sequelae, meaning they just didn't really get better, or they have delayed sequelae. So I come in with a headache and some confusion. You diagnose the poisoning. You put me on 100% oxygen. I get better. You send me home. And then days or weeks later, I come back with some sort of deterioration that can sometimes be quite severe. And so that's called delayed.
Hey, folks, but we're not getting right to the show because you're listening to the free foam feed of EMCrit rather than the members-only feed. Now, I'll put you out of your suspense. This is a full episode. You're not going to be cut off. Don't get upset that, you're hearing this and now 8 minutes from now, you're going to be listening, super excited by what you're learning, and then all of a sudden, and no more episode. You never want to hear that sound again. You're not going to hear it in this one, but you're going to hear it in a bunch of others because you're not a member. And membership is so cheap and so beneficial to the care that you could provide your critically ill patients in the ED or ICU that it's just crazy that you're still hearing this message. So go to emcrit.org/join, become a member, do it before the end of the year. You could write it off on your taxes. You could use your CME funds. And then all of a sudden you get all of the stuff that is not available in the free feed, and you never have to hear this message again. Please consider joining, and thank you for listening.
Neurosequelae. And that was very clearly the original outcome these guys intended to study. And it wasn't apparent until really doing this forensic literature review that the outcome that they published in their paper wasn't the one that they set out to study. And I guess I don't mean to sound overly critical, but I think it is fair to say, or at least it's my impression, that they set out to study outcome A, and they ended up reporting outcome B. And outcome B is, when you really pick it apart, it's the one that, in my view, was most likely to cast a favorable light on hyperbaric oxygen as a therapy. So I've rambled quite a lot there, but I think the key point, if you just read the abstract, it looks like a home run study. If you read into the details and dig into the gray literature, it's a different animal altogether.
Yeah. So, Dave, would you say, and this is your opinion, it's absolutely fine, that there is evidence it doesn't work, or there is no evidence that it does work?
I wouldn't say the former. I think there are reasonable grounds to think that hyperbaric oxygen might do something for patients with carbon monoxide poisoning. We just don't have good evidence to support that yet. Based upon the Weaver trial, if it does anything, it's probably not that much of an effect size in terms of their eventual sort of cognitive function. One of the things they did do is they picked apart the neuropsych testing in the treatment and control arms. And honestly, they're just not that different. So I make room for the possibility it might do something. And I will admit, we all do things without good evidence behind it all the time, right? So if I'm on call for Poison Center and a patient who is like the one you described, maybe a bit worse, shows up at a center with a chamber, I'd probably dive him. But to be honest with you, I wouldn't know whether I'm doing something beneficial for him or not. So I just leave it at that. It's, people like to have opinions on this therapy, but the fact is that nobody on the planet knows what this therapy really does, which patients it does if it does anything, who the optimal patients are, what the right regimen is, and whether the benefits are worth the risks.
What are the risks?
I think that the main one you alluded to in the outset is middle ear barotrauma, and that happens somewhere in the sort of 2 to 10%, depending on the series. It's usually mild. Rupture is rare, maybe less than 0.5%, and that's just all from failure to equalize during compression, stretching of the tympanic membrane. You can sometimes get sinus barotrauma, like pain over the frontal and maxillary sinuses. It's self-limited. There are these rare reports of oxygen toxicity seizures. I've often wondered if those are oxygen related or just from the precarious nature of brain tissue in the face of carbon monoxide poisoning. And rarely pulmonary barotrauma. That's rare, but I'm usually in people with under-recognized or unrecognized bullous lung disease. So I don't want to paint it as a dangerous therapy. It really is, especially one to 2 or 3 runs of the stuff is generally pretty safe.
So then in 2025, and you could give your opinion, and then maybe you could give, if you have an idea of it, the consensus of toxicologists, who should definitely get dived? And you might say no one, but is there a group who, even with the absence of evidence that is really good, you'd say, yeah, that patient should definitely still dive?
My opinion is that there is no patient, I can't think of a patient where one can confidently say this patient must undergo hyperbaric oxygen. Intuitively, patients with more severe disease are the ones who are more likely to derive a benefit from intervention. If you're treating hypertension, if I on internal medicine have a patient with a pressure of 170 on 120, and you in critical care have a guy with a pressure of 250 on 180, intuitively, your guy's going to benefit more from lowering of blood pressure acutely. That may or may not apply here. So, intuitively, the people who are sicker are the ones who are most likely to benefit. We just don't have data to back that up. So I got to say, I'm hesitant to say, I don't think that there is a scenario where hyperbaric oxygen is necessarily indicated. And I guess the corollary of that is you can always make the argument based on the evidence that it's proper not to that you are within your rights to not dive somebody. And people might disagree with that, but there's no data to back it up.
And that decision, I think, is easier to say, okay, they're pretty severe, let's dive them, when you are in a center that has hyperbarics. Transfer is hours. Is there any patient you would consider advice? Like, let's say they called you, I need some advice, I'm at this community hospital, I'm an hour out. Is there any patient worth transferring for hyperbaric?
I get these calls. No, I have to say no. If I'm struggling to make the case to dive them when they show up at the door of a place with a chamber, it's harder to make the case that you should put them in an air ambulance and send them a few hours to the nearest chamber. So no, I don't think so. I'm going to get hate mail from the hyperbaric community.
Oh, I know. I'm waiting for it too. But yeah. And we'll absolutely, I'll say it here, I'll say it again at the end. Anyone who wants to come on and give a counter opinion, I've been looking. I actually reached out to Steve Tom. He does not want to deal with this anymore, at least in the public eye. He's been scathed enough. He doesn't want to deal with this. So I'm sure there's a pro-hyperbaric toxicologist who will love to come on and dispute all this.
I'm prepared to change my mind on the topic, but we need it. This is the point I made in that article. Like what we need is a properly done, big randomized trial, multi-center trial with clearly specified outcomes, endpoints. And there's plenty of patients to power this trial. The problem is, and the reason why I worry it'll never get done, is because so many of the people who've got the keys to the chambers already believe that the therapy works, or that there's a set of criteria, or that you might be somehow harming a patient by not randomizing them, by that there are people who shouldn't be randomized. Like we don't know. I wish we had better data. We don't, and so we're operating in not an evidence-free zone, but a zone where the evidence looks more definitive and the recommendations look more definitive than the evidence supports.
Yeah, it feels very much like thrombolytics for stroke to me, where it's just such
I'm not going there. I've seen the fights on Twitter.
Yeah, we can get you some real hate mail. Now, Dave, and I've noticed this so consistently, and it just, as a person obsessed with oxygen physiology, it just drives me nuts. Everyone says, okay, we'll just put them on 100% oxygen, and then they put them on a non-rebreather mask at 15 liters per minute, which is providing 60% oxygen. So when you are saying not to dive these patients, are you giving them the proper advice, which is you need something besides a non-rebreather at 15 liters a minute?
Yeah, I got to say, and this is going to sound crazy and almost probably, blasphemous. We don't even know if oxygen makes a difference. Oxygen's never been compared to anything else. We just do it because we know it hastens the acceleration of carboxyhemoglobin. So what's your practice normally, Scott?
High flow nasal cannula will be the most comfortable way. Or if you don't have it, you can just put them on a non-rebreather at flush rate, which in both Canada and the United States, if you open up the flow meters as much as they could go counterclockwise, then it's around 50 liters a minute. And that will give a near 100% FiO2.
We normally just use airboat.
Okay. Now, you're in Canada, Dave, where medical legal is not as huge an issue as it is in the litigious states. I fear, even though I agree with everything you've said, that if I don't dive this poor pregnant mother, and then there is neurologic sequelae or a loss of the pregnancy, I'm going to get sued. What would you say to your American compatriots where, and obviously institutional protocols are the way to save yourself from this, because then it's not your decision, it's the hospitals or the emergency departments. But if an individual called you, one of your buddies called you from the States and said, should I dive this patient? Does that play into your recommendations at all?
Well, that's a question I didn't see coming, because I don't really think, I think we do practice differently here. I just don't feel the medical legal threat. And I got to say, if I'm sued one day for specifically saying don't dive this patient, I'm going to be perfectly armed to defend myself. And so it's tough because the climate there is so different. I guess if you choose to dive them, you'd be diving them to cover your backside, not so much to help the patient's outcome necessarily. You'd be doing it because somewhere somebody said there's a guideline somewhere or a recommendation somewhere you should dive them. The NHS in England has looked at this very critically, and they say we don't justify this. We don't think this therapy is worth doing. So it's in direct contrast to what Steve Tom or Chris Tomaszewski, for example, might have said in Goldfrang. So I don't know how this is going to go over with your listeners, but if you're working in the States, but you can easily defend not diving somebody. And if someone's got neurologic sequelae and they weren't dived, who's to say that would have been any different? The evidence that hyperbaric oxygen would have prevented those is tenuous at best.
Yeah. I think you could win the case. The goal for many of us in the U.S. is never to get sued, because even when you prevail, you don't really prevail. The solution that we take in the States, for better or for worse, is I think we're deferring these decisions to our toxicology centers. And everyone has access to 24-hour toxicology in the U.S. And as a result, they're going to be making this decision. So they're going to be the ones.
And it's probably the case that different centers have different approaches to this.
100%.
I'm sure they do. Yeah. So, and when groups of experts have different answers to the same question, that tells you something
100%.
about the quality of the evidence informing the decision.
100% agree. What have I missed that I should have asked you, Dave, that you want to get out there to the listeners?
I don't know. I guess cyanide is always a potential consideration, right? So, I've been involved in a couple of cases where cyanide wasn't recognized. And so in your patient who comes in from a residential fire, the key barometer here is a high lactate, at least 8 or 10, often higher than 15, but they've often got much more profound cardiovascular and neurologic toxicity than you just see with carbon monoxide. It's important not to lose sight of that. And so we did have one case. We actually, she got hydroxycobalamin as part of her management, but this patient, we published the case, had been extricated from a fire and was sent for hyperbaric. This was maybe 15 years ago, and came back, and we thought, she's got cyanide poisoning. Maybe we should deal with that first. I think that's, if you're presented with a really sick carbon monoxide patient, keep in mind that it's often coexists with cyanide, and the key lab barometer is the high lactate. And I would tackle that first before worrying about sending to a chamber.
I love that point. In fact, most of our EMS services are keyed in. Any patient who's decompensating after smoke inhalation, they all get it in the field, which is a real boon. But if not, you certainly should have access to it in your ED and give it immediately. I don't know about you. I don't even wait for the lactate. If I have a hypotensive patient after smoke inhalation, I'm just giving it because it's such a bolster to their blood pressure regardless of the source that it's just a bonus.
The volunteer studies of that antidote back decades ago were actually halted because of hypertension. So it's hardly a side effect when you're dealing with a cyanide patient.
100%. All right. Anything else you want to add, Dave, before we
I think we've covered all the bases. I look forward to the hate mail.
All right. Me too. I can't thank you enough for coming on. This has been a great pleasure.
Thanks, Scott.
All right, folks. Just at the end here, I want to add in two things. One is screening for cardiac injury in carbon monoxide. I'm sure if you call your tox center, they're going to tell you this, but a lot of times that doesn't happen for a little while, and it might happen after the initial labs. But carbon monoxide could cause some pretty gruesome forms of cardiac injury, and of all forms. It could cause actual coronary blockage. It could cause direct muscle injury. It's not good stuff. Like, your heart does not like carbon monoxide, so you should be screening for it. Now, I have a paper linked in the show notes that has an entire pathway for dealing with these patients. But the stuff you should know at the beginning before you talk to your tox center is the recommendation is to get an EKG, which you'd probably do anyway for any tox patient, a troponin, high sensitivity if you have it, and a BNP. And those three, if any of those are abnormal, then you should go further down the pathway of investigating cardiac injury in carbon monoxide patients. So that's just something to look at that paper. Highly recommend. And then something I found in the Internet Book of Critical Care is isocapnic hyperventilation. And this is predicate on the idea that if you hyperventilate, you clear the carbon monoxide quicker. In fact, with rates comparable to hyperbaric oxygen. But the problem is that you become severely hypocarbic unless you're inhaling carbon monoxide. Now, obviously, I mean carbon dioxide here, slip of the tongue. Thank you to Ellis Kurzman for being the first one to immediately point out the error, allowing us to correct it. And then you could actually have isocapnic hyperventilation, have very rapid rates of clearance without all of the problems of the hypocapnia. And these patients, especially with their potential for neurologic injury from the carbon monoxide, causing cerebral vasoconstriction doesn't seem like the smartest move in the world. So you really want isocapnia, and this could do it. Now, you could jury-rig this, but there's also a commercial device. I don't know how Josh finds this stuff, but a commercial device that dials in your carbon monoxide levels as the patient is hyperventilating. And If you keep upping it slightly higher than normal, then the patient will have a hyperventilatory drive that will bring their CO2 down to normal, but still keep them at maximal Kussmaul ventilation. So this is kind of cool. I don't know if I would ever do this. This is not at the level of truly proven yet, but I suppose if you had a severe toxicity and you couldn't get them dived, this would be another option. So look at that. It's pretty cool. All right, I think I'll leave it there. We're getting up on time. This has been Scott Weingart for the EMCrit podcast saying bye-bye. As always, promote dignity, relief, and warmth. Very rapidly, some current projects you may be interested in. The Awake and Aware Conference, Scottsdale, Arizona, February 2027. Its Kickstarter has sold out, so the conference is live. Unfortunately, you missed the super discounted tickets, but the full price tickets are now available, and I will tell you the link at the end of this discussion. But that conference was amazing last year. It will be amazing this year. The Out on Time course, it is our charting course, our malpractice avoidance course, our getting out on time course, feeling on top of your shift efficiency. The spin class, that is our vertigo and dizziness mastery class. It is to get you to the point where you will be eager rather than dreading picking up a dizziness chart. We have the Resus Leadership Academy. That is our online fellowship to take you from emergency medicine or hospitalist to aggressively potent resuscitation doctor. You will be the person in your department leading the game on resuscitation and acute critical care. The Unburnable course, that is our burnout prevention course, our finding joy and flourishing in your career course. That is a cohort online course, so it is done in real time, and it has been lovely. This is our 5th cohort. And then, last but not least, the Reanimate course. That is our eCPR, ECMO CPR, and resuscitative ECMO course. It sells out every year. If you want to come, the time to buy tickets is now, because every year I get people, 4 months before the conference, they're like, I really want to come. Well, guess what? You can't, because I told you for the 5 months before now that they sell out every single year. You should have listened. So if you want to check out any of that stuff, come to emcrit.org/stuff. emcrit.org/stuff. That's emcrit.org/STUFF. So I've loved talking to you. I'll talk to you again soon. Scott Weingart saying bye-bye.